Hope everybody can see the screen.
Yes, sir. So
Yes.
please go ahead.
Thank you. Thank you, ma'am, for the introduction. I welcome you all to the webinar on cataract, basics of cataract, and what is the role of a counselor in advising when a cataract surgery is advised. To understand the role, we must understand what is a cataract, what are the types of cataract, and what are the types of cataract surgeries. So this is my topic. Unless a counselor understands what is the cataract, anatomy of the lens, and types of the cataract and types of cataract surgeries, a counselor will not be in an ideal position to counsel the patient regarding the timeline for the surgery and the consequences of undergoing the surgery. So to begin with, I'll teach about lens anatomy for 5 minutes, and we'll have a small brief session on types of cataract and then followed by types of surgeries. Before I begin the session, I would like to put up a poll on this question. A patient has mature cataract in right eye and brown cataract in left eye. If counselors were to advise surgery, which eye will you advise surgery first? Is it the eye with the mature cataract or the eye with the brown cataract? You can answer in the chat box, or you can answer in the chat box.
Okay, I'm going to just close this poll, and these are the results we got.
Thank you. Thank you. So I'm not going to give the answer now. I just wanted to pose the question. We'll try and get the answer for this question in the rest of the 20 minutes that I'm going to spend now. So first, to begin with, lens anatomy. Lens has basically three parts. The innermost core is the nucleus. The second covering is the cortex, and the outermost covering is the capsule. It is akin to a mango with the innermost part, that is the nucleus, is the hardest, followed by the cortex, which is a little soft compared to the nucleus, and the outermost covering is the capsule. But if you go in depth, the nucleus is further divided into the centralmost part, which is the embryonic nucleus, followed by the fetal nucleus, infantile nucleus, adult nucleus, and the cortex. So based on the stages of development, the duration at which the nucleus develops, these are the parts of the nucleus and the cortex. And the newest fibers are formed from the equator and enter into the lens. Coming to the types of cataract, basically cataract can be classified into congenital, developmental, age-related, complicated, and traumatic based on the causes. If the patient develops cataract at birth, then it is called a congenital cataract. During developmental stage, if a patient develops, it is called a developmental cataract. Age-related, because of aging after 40 years or 50 years, if the patient develops cataract, it is age-related or senile cataract. And complicated cataract occurs due to uveitis, due to inflammation in the eye causing a cataract. And traumatic cataract is caused by any trauma. For our discussion today, I'll mainly deal with age-related cataract because this is the most common cataract that we see in a regular OPD. Based on the structures, the cataract is divided further into nuclear sclerosis or nuclear cataract, cortical cataract, posterior subcapsular cataract, posterior polar cataract. All these together are called the immature cataract. Apart from this, there is mature cataract, hypermature cataract, or Margagnanian cataract, brown cataract, and black cataract. Let's see how all these cataracts develop and how they progress. So the first type is the nuclear cataract. Like we understood in the anatomy, the centralmost core of the lens is the nucleus. Like you can see in this picture, the centralmost core is opacified. The surrounding structures are all transparent, while the centermost core is opacified. Such a cataract is called the nuclear sclerosis cataract. Such cataracts cause myopic shift. The patient will develop myopia as a result of developing such cataracts, and patient can read better with myopic correction. So this is called second vision, when the patient is able to read better with myopic correction. This happens in the early stages of nuclear sclerosis cataract, but after a while, this near vision improvement will come down. If a nuclear sclerosis is not treated, it progresses into brown cataract, and even if at this stage, if you don't intervene, it progresses into a black cataract. Nuclear sclerosis 1, 2 to 3. As you can see, this is a little white. Here it is amber colored, and here it is brown colored. This is how a picture will look to a patient with each of these stages of cataract. Now coming to the second type is the cortical cataract. Now, as you can see, the opacity is not in the center of the lens, it is more in the periphery, and these opacities are wedge-shaped. So such a cataract is called a cortical cataract. If a patient doesn't undergo surgery at this stage, it progresses into a mature cataract. Now, what happens if a patient still doesn't undergo surgery at a mature stage? It can progress in two ways. It can either become a hypermature or Morgagnian cataract and cause phacolytic glaucoma if untreated. The liquefied cortex from the capsule leaks from the capsule and causes inflammation. While in the mature intumescent stage, it can swell up and push the iris forward and cause a phacomorphic glaucoma due to angle closure. As you can see in the picture, I've shown the same thing as pictures. A mature cataract, if left untreated, can develop into a Morgagnian cataract. Can you see the lens? So this lens has liquefied cortex, and the central core of nucleus, which is a little hard, has sunken and sunk down. This is called a sunset sign. This is a Morgagnian cataract. If the patient doesn't undergo surgery at this stage, the liquefied cortex, as you can see in the next picture, has come out and settled in the anterior chamber. And this will cause an anterior segment inflammation. And this is called phacolytic glaucoma. As you can see from both the pictures, the anterior chamber is not shallow, it is well formed. In the second picture, if you see the lens, it is swollen. The anterior capsule is almost convex. If at this stage we don't advise surgery, the cataract can progress and cause phacomorphic glaucoma. As you can see here, the anterior chamber is shallow, there is corneal edema, and there is a mid-dilated fixed pupil. This is the presentation of a phacomorphic glaucoma. In both the cases of phacolytic and phacomorphic glaucoma, the intraocular pressure will be high and the patient will have severe pain and inflammation. So the first role would be to reduce the inflammation by giving topical steroids, a cycloplegic in case of phacolytic glaucoma, but cycloplegic is contraindicated in phacomorphic glaucoma because the anterior chamber is shallow. And you give IV mannitol or oral hypoglycemic drugs depending on the IOP to reduce the intraocular pressure and then proceed with the surgery. So to summarize everything, nuclear cataract can cause a myopic shift. A cortical cataract can cause a hypermetropic shift in the patient's refractive error. If untreated, a nuclear cataract progresses into a brown cataract. If brown cataract is not treated, it progresses into a black cataract. Even at this stage, if the patient doesn't undergo surgery, it can progress into a posterior dislocation of lens. The lens can spontaneously get dislocated into the vitreous. But the time it takes for the entire process to happen, the progression from nuclear sclerosis 1, 2, 3, 4, brown, black, and posterior dislocation is pretty long when compared to the progression of cortical cataract to mature, hypermature, phacolytic or phacomorphic glaucoma. So we come to the third and fourth types, which are the posterior subcapsular cataract and the posterior polar cataract. So posterior subcapsular, if you remember the lens anatomy, the opacified portion is the portion just beneath the capsule, posterior capsule. This is the anterior capsule, the central nucleus, which is transparent again, and the posterior part just beneath the posterior capsule is opacified here. Here, if you observe, this is the anterior posterior image. The posterior capsule is also opacified. So this is called a posterior polar cataract. So such cases, we have to be careful because the posterior capsule might be weak in a patient with posterior polar cataract. So this is how an image for a patient with clear lens will look, while a patient with posterior subcapsular or a posterior polar cataract will have severe glare. So what does a counselor do when each of these cataract patients with each of these types present? So this is a rough guide as to how you can counsel. A patient with less than 660 vision, a counselor has to spend more time on counseling for early surgery, preferably within a week. If the patient has a vision between 624 and 660 and has disabling glare or has difficulty in carrying out routine work, you can explain about the nature of the cataract and how it progresses. What happens if the cataract surgery is not done in time? What are the consequences? And have them plan the surgery within a month. This is a rough guide. You'll have to change depending on each patient and each situation. For the third level, if the vision is 618 or better, is when we'll have to make a lot of choices. If the patient is a driver whose occupation depends on whose ability to earn depends on his vision, then you have to advise the surgery a lot earlier than for a patient who is retired, who doesn't have much driving to do, who's very comfortable doing his desired day-to-day activities. Such patient, you can give a choice of having a review checkup or maybe 2 or 3 months later and see how the cataract progresses and probably take it from there. So the duration to undergo surgery will depend on a lot of factors. The cataract type, the occupation, patient's age, his ability to earn depending on the vision, and the patient's if the patient is convinced that his vision is poor. Now coming to the types of surgeries. Now this is going to be very interesting. So we know the common three types: extracapsular cataract extraction, manual small incision cataract surgery, and phacoemulsification. While in extracapsular cataract extraction, we'll have to suture the wound. In the next two procedures, we don't suture the wound as a routine. But if you go into the history, it gets even more interesting. 4,000 years back, we were treating cataract with couching. I'll show you videos for all of these procedures. During the 17th century, it was intracapsular cataract extraction, which will involve removing the lens as a whole. So removing the capsule, the nucleus, and the cortex, everything together with a cryoprobe. The cryoprobe is has freezing temperature, so it just gets attached to the lens, and you pull the whole lens complex out of the eye. During the 19th century, we developed a technique called extracapsular cataract extraction, which involves leaving the capsule in the back. So you just make an opening in the anterior part of the capsule, remove the lens, and place an intraocular lens. In the earlier procedure, intracapsular cataract extraction, since there is no capsule, you cannot place a artificial intraocular lens in the eye. So we'll have to give high hypermetrope glasses, which can cause some discomfort on their own, like jack-in-the-box phenomenon and magnification of images. With the introduction of intraocular lenses, ECCE was possible. And with small incision cataract surgery, since we have a self-sealing tunnel in this procedure, the need for suturing the wound went away, and we were able to remove the lens and keep a intraocular lens. Phaco made it even more smaller, even more made the incision even more smaller, 2.8 to 2.2 incision. And the most recent one is femtosecond laser assisted cataract surgery. So for our discussion, I'll take mainly SICs and phaco, since these are the most common procedures that we are doing across the world. So this is couching. This will involve taking an instrument inside the eye, releasing all the zonular adhesions, and then pushing the lens into the vitreous. Something similar happens in black cataract. Black cataract left untreated because of the weight and the capsular weakness can at sometimes progress and develop into a posterior dislocation at some point. Next, we go with intracapsular cataract extraction. So here, an incision parallel to the limbus. If you see, this incision is parallel to the limbus. It is around 10 mm. Is made, an entry is made into the anterior chamber. Through that entry, the wound is extended using a scissors. Once the wound is opened, adequate to the structure of size of the nucleus, We take in a cryoprobe. Let the cryoprobe attach itself to the lens complex. And once it is completely adherent, the entire lens complex along with capsule, nucleus and cortex, everything is removed from the eye. You have vitreous coming out. The vitreous is cut. The sutures is done. The biggest disadvantage of this procedure is the vitreous coming out. Since the vitreous is exposed, the chances of a patient developing endophthalmitis or panophthalmitis subsequently is higher in a procedure with a procedure like intracapsular cataract extraction. Once the vitreous is cut, the wound is sutured. And after the rehabilitation period, spectacles are given. We go into the next commonly done procedure, which is the extracapsular cataract extraction. Here, the wound is almost similar to a intracapsular cataract extraction. A 10 mm wound parallel to the limbus is again made. Here, the wound is entered. With entry alone, a cystitome is taken and the capsulotomy is done. So the surgeon has made small openings in the capsule and removed the anterior part of the capsule. Now, once that is done, the surgeon enlarges the wound and removes the nucleus from the capsule. Here, only the nucleus is removed. The rest of the cortex is in the bag. Now, what the surgeon does is takes a Simcoe cannula, removes the cortex, and then places the intraocular lens. In the bag. Once the lens is placed, the wound is sutured. Depending on the size of the wound and approximation of wound, 5 to 6 sutures are placed. So like you can see from both the procedures, intracapsular extraction and extracapsular extraction, the wound is 10 mm sized approximately, and you need sutures to oppose the wound. The most common complications or difficulties that surgeons used to face in the early stages of training is the wound opposition, the space between the sutures. They should be adequately spaced. If the sutures are not here, if you see, all the 5 sutures are radially placed, equally spaced, and of equal size. If such a wound is sutured like this, then the chances of astigmatism is less. If the sutures are either too loose or too tight, then it can cause a lot of astigmatism. Sometimes loose sutures can cause wound leak. In such cases, you'll have to take up the patient for resurgery and resuture the wound. Any leakage in wound is prone to cause infection, post-operative infection. So these are the disadvantages of doing a extracapsular cataract extraction. Now we go with the manual small incision cataract surgery, which is the most commonly done surgery across the developing countries at present for advanced cataracts. Here, instead of an incision that is parallel to the limbus, here an incision is made. This is a scratch incision. Incision is made a frown incision away from the limbus, 2 mm away from the limbus and not parallel to the limbus. So it is a triplanar tunnel that we are trying to form. The first incision is one plane. Now the tunnel is made with the crescent. So this is the first plane. This is the second plane. Now that the tunnel is formed, a keratome entry is made, completing the third plane. The keratoma is going into the second plane, and the dimple is made, and the third plane is made. Because it is a triplanar incision, once the wound is closed, it self-seals. There is no need to suture this wound. So this is the biggest advantage of small incision cataracts, manual small incision cataract surgery. So this is the first plane incision, second plane, and the third plane of entry into the cornea. Now a continuous curvilinear capsulorhexis is made. This is based on the size of the cataract. Hydrodissection is done. The lens is prolapsed from the back into the anterior chamber. Once the lens is into the anterior chamber, you take an irrigation vectis and remove the cataractus lens from the anterior chamber. Now the cortex attached to the bag is removed with the Simcoe cannula. And lens is placed, intraocular lens is placed, and the side port entry is hydrated. So this is the manual small incision cataract surgery. The main difference between extracapsular and manual small incision is the wound. You need sutures to oppose the wound in an extracapsular cataract extraction, while in a manual small incision cataract surgery, the wound is triplanar and hence it seals by itself. You don't need any sutures to oppose the wound. Now we go into a phacoemulsification video. Phacoemulsification, I'm going to show two videos, one with a softer cataract and second video would be with a harder cataract. Here, 2.8 mm incision is made. Rhexis is already made. The surgeon is taking the phaco probe inside. Now he's breaking the nucleus into small pieces and then eating. Look how relatively easy it is for the surgeon to break this into smaller pieces. So he's breaking a soft cataract into smaller. The nucleus grade should be the NS2 to 3, which is ideal for learning. Now the surgeon has removed all the nucleus part, broken it into smaller pieces, and the cortex is following. The epinucleus is following. Now the cortex will be removed and the foldable intraocular lens is placed. Now it is loaded into the cartridge. The cartridge is then placed inside an injector. Then it is injected into the anterior chamber. This is how a foldable IOL is placed in phaco. Now we'll go into the cataract surgery that needs the maximum skill. Here, if you remember, it's how much easy it was to chop the earlier wound. Now we go into the harder cataract where this is one of the senior surgeons at Aravind trying to deal with the harder cataract with phacoemulsification. He's making a deep trench. Once that is done, he's trying to break it. Now I want you to remember and compare the earlier video with this. Look at the effort that the surgeon takes. Look at the patience that the surgeon needs to have to break this nucleus. It's very hard, brown cataract. The surgeon is taking his own time and being very patient to do this surgery. He has to be absolutely sure that there are two pieces initially and then break the nucleus into even smaller pieces. So you can see this is the capsule. The blue stained portion is the capsule. The surgeon is trying to break it into even smaller pieces so that they can be eaten separately, emulsified separately. If you are not too careful with this, it can cause a zonular dialysis or weakness, and that can result in a intra-op complication and may have to be converted into a small incision cataract surgery, manual small incision cataract surgery. Because the time also it takes for the machine to emulsify that particular piece of cataract, because the dense core is very hard to emulsify. The rest of the surgery will be the same. Once the nucleus is removed, the cortex is aspirated, and finally the lens is placed in the bag. This is how cortex is removed from the bag. As you can see, the bag margin where the capsular excess was done. The surgeon is polishing the bag. Bag is completely inflated. Now the surgeon is injecting the lens into the bag. So the basic difference between an SICS and phacoemulsification is, to summarize, the wound will be 6 to 7 mm. It will depend on the grade of the cataract in an SICS. You don't have to apply a suture, while the wound size is around 2.2 to 2.8 mm in phacoemulsification. The astigmatism induced by the wound is higher in SICS when compared to phaco. The cost of surgery for patients is less expensive than phaco for manual small incision cataract surgery. Why is the cost less? Because there is less recurring cost for each patient, and you don't have an expensive machine or phaco tips to deal with. And the learning curve for the surgeons is also less when you compare a phacoemulsification. The basic advantages of doing a small incision cataract surgery is it is safer for advanced cataracts, it is quicker, less expensive, and can help reduce high preoperative astigmatism with a relatively less expensive surgery. Here, the advantages of phacoemulsification is it can be done under topical anesthesia, and patient can get back to his work even quicker than a manual small incision cataract surgery. If you want to correct high astigmatism in phacoemulsification, you might have to go for a toric IOL, which could make the surgery a little expensive when compared to a manual small incision cataract surgery. What is the role of a counselor? Now that you have understood the lens anatomy, types of age-related cataract, and the types of surgeries that we commonly do, the counselor should be able to have a very clear knowledge about the nature of cataract and the surgery of choice for the patient. And if that is clear, then he or she should be able to give clear information, and also give a tentative timeline for undergoing the surgery, and also give what are the alternate options. A patient with nuclear sclerosis having -2 with vision improving to 6.6 can be advised spectacles for also for a short while, and then have a review, have the patient come back for a review. A patient with a hypermature cataract or a Morgagnian cataract has to be clearly and explicitly told that they can end up in a painful situation where we might have to go in for a emergency surgeries with the visual outcome not so much promising. So we'll have to give a timeline based on the patient's occupation, age, and the chances of a complication occurring in the future. The counselor should help the patient to arrive at an informed decision. So coming back to the initial question, if I open the poll now, having said that all the types of cataract, the time it takes for the surgery to be done, The poll is open now. Can you answer the question now? If enough people answer the question, I think I've done my job.
After you give your choice, please remember to hit the submit button at the bottom of the screen. Only then we'll see your response.
Yeah.
Okay, about half of them have responded. I'm going to end the poll. So, I'll share the results. Please give your explanation on that.
Yeah. So if I were the surgeon and I see a patient with a mature cataract in one eye and brown cataract in left eye, right, I would advise the mature cataract surgery first, because the chances of a mature cataract progressing into a mature intumescent cataract or a Morgagnian cataract and causing pain due to phacolytic or morphic glaucoma is higher than a brown cataract progressing into a black cataract and getting dislocated into the posterior chamber. So given a choice, I would advise mature cataract first. Having said the answer, if I were to ask another question, and will they be able to answer in the chat box, ma'am?
Okay, I'll open the chat box. Everyone can use the chat box. Yeah.
Yes. So if I were to ask for two factors, if I were to ask the counselors who are participating in the discussion today, if I were to ask you to advise surgery, which type of surgery would you advise? Phaco or SICS? For the mature cataract, since I am the surgeon, I'm going to advise mature cataract first. So that is not up for choice at present. Phaco or SICS, and what are the two factors that it will depend on?
Maybe we can just ask one question, so just to make it easy.
So what are the two factors that will make you decide whether to go for Phaco or SICS in this patient? Top two factors. You can think about, there'll be a lot of factors, but if I were to give only two options, I
think they're saying SICS or FACO.
No.
The question, please understand, the question is what will help you decide whether it is FACO or SICS? What other things will you look for? Age of the patient, occupation of the patient, some of you have said. Yeah, that is the kind of answer we're looking for. Yes. So what else will you look for to decide whether to go for SICS or FACO?
What are the factors? Cost. Yes, cost is an important factor.
Occupation, expertise of the surgeon.
Yes.
Time duration.
Age, support, capsular support. Yes. Great. Great to know. So the expertise of the surgeon will come first, and the patient's ability to pay. Yes, we can do Phaco or SICS, but it will eventually come down to how hard the cataract is and what is the skill set of the surgeon. These are the two main factors that will determine whether we go ahead with a Phaco or SICS for any patient. With that, I'll close my presentation. Thank you for joining us. And can we have the question answer session now, or can we have it at the end?
Yes, I will have the question. So requesting everyone, please use this Q&A button, which is on your Zoom screen. Please use that to type in your questions. You'll not be able to type in the chat box. Please type your questions using the Q&A box. I see few of you are raising your hands. I request you to please type the questions in the Q&A box. So Parvindra Kumar has observed surgery was done even 4,000 years ago.
Yes, it is interesting. Yes. Thank you. Good evening, Mr. Vimal Dutt. If there are any questions,
is SICS safer for brown cataracts?
Yes. So the brown is a relative word. It will depend on the skill set of the surgeon. but in general, it is safer to do SICS in brown cataracts. Which degree of cataract is perfect for phaco? For a beginner surgeon, it is better to begin with NS2 to 3, which will help him understand the nature of the nucleus, get to understand the hardness of the nucleus, and then learn from there. So the degree of cataract perfect for phaco would be NS2 to 3. How to handle a posterior polar cataract in phaco is one of the most important factors is you don't let the anterior chamber become shallow. So you always keep the anterior chamber formed and do not do hydrodissection as you do in other cases. You do a hydrodelineation, wherein the nucleus is separated from the cortex. In a hydrodissection, the cortex and the nucleus is separated from the capsule, while in a hydrodelineation, only the nucleus is separated. So once the nucleus is separated, then you slowly remove the adhesions, cortical adhesions from the capsule with visco. What is the average cost of SICS and phaco in Aravind Eye Hospital?
I'll type the answer, so you can go on to the next question.
Could you please explain on yellow IQ lens, single piece, multi-piece? So the next session will be on all these questions. So the next speaker will answer the question. Mr. Shivanand will answer that question. Why is phaco expensive? So this is the reason. Phaco, you need a cassette for the machine. You need an expensive machine first. Then you need the tip. The tip has to be changed. It has wear and tear. So close to 1,000 surgeries can be done with a single tip. Then you have to change the tip. Tip cost is involved. Then the other machine servicing cost is involved. While SICS has relatively 10 to 12 instruments, which are all disposable or can be reused. The ability to reuse instruments in phaco is very less when it comes to cassettes. For not highly educated patients, how to explain simply? The easiest way to explain is to do with a picture. The picture is going to make all the difference. If you show a picture with an SICS wound and a picture with a phaco wound, then patient will understand what happens. If patient is able to understand with the picture, then you go into the video. ACIOL, we have stopped doing anterior chamber IOL at Aravind because it causes inflammation and can cause glaucoma. So we use secondary IOL procedures like scleral fixated IOL or iris fixation IOL. 3-piece and PMMA rigid, all these details about the IOL will be again handled in the next session. Mature cataract, sir. Mr. Ranjit Radha, it is mature cataract because the mature cataract can progress into phacolytic or phacomorphic glaucoma and cause pain at a relatively quicker time than a brown cataract. When surgeon advised to take toric lens, then what procedure we follow, phaco or SICS? It should be phaco because SICS, you can't control the amount of astigmatism that it causes. Any toric calculator is going to give you for phaco incision size 2.2 or 2.8. It will not take into the account the size of the SICS wound. So toric lenses and the premium lenses can be done only with phaco. Is any safe laser refractive cataract surgery for brown cataract? Femto can be done. Again, it will involve emulsifying the nucleus with the phaco probe. So it again comes down to the skill set of the surgeon. For semi-dilated pupil, if you want SICS for the mature cataract, then any kind of complexity on iris. Okay. So for mid-dilated pupil, we can use iris hooks. Or you can cut the iris at small points, small cuts in the iris to dilate the pupil. If we use hooks, then the pupil shape will not change. When you do a cut iridectomy, then it can change the shape of the pupil and cause some amount of glare to the patient. Ms. Vinayak Krishnan has asked, what is the difference between phaco and FLACS? Which one is better to do? So FLACS is the most important, most recent advance in the field of cataract surgery. the outcomes will be similar, or FLACS will be slightly better than phaco in the hands of a experienced surgeon. Is cost is related than we do? Is it okay or not? Swapnil Kawate, who should counsel method of CAS surgery, phaco to patients? Doctor or counselor? Both. I would say counselor has a bigger role because doctor can decide on the surgery. Counselor is in a better position to spend more time, understand the patient even better, understand the patient's situation, occupation. Both have equal roles, and they should be a team. It's a teamwork. So you'll have a lot of learning, both the doctor and the counselor. When we start advising patients and counseling patients, both will have a lot of learning, and the learning should be shared with each other. Because not every patient is the same. Every single patient is unique with his own set of challenges, and both social and scientific. Grade of cataract, patient's occupation, patient's expectations from the surgery, all these things have to be taken into account. So both the doctor and counselor are responsible for the counseling. For brown cataracts, Mr. Krishna Kumar Tanikachalam has asked, for brown cataracts, if patient also wants to treat high astigmatism with toric, if the bound cataract is manageable, amenable to be emulsified, then you can go ahead with the phaco with toric. But if it is very hard and it is a 90-year-old patient with a very weak back that is prone to get into a zonular dialysis or complicated situation, it is better to go ahead with an SICS and try to correct as much of the high astigmatism as possible with the wound. Congenital cataract is a totally separate topic that has to be dealt separately. Rituraj Singh has asked what difference is between SICS and MICS. So SICS, when I say MICS, it is manual small incision cataract surgery. When it is MICS is micro incision cataract surgery, which is a 2.2 mm incision. Phaco, we say 2.8 mm. MICS is micro incision cataract surgery, which is 2.2 mm incision. MICS and phaco both are done with the same phaco machine, only the size of the incision varies. So MICS is micro incision cataract surgery. SICS is small incision cataract surgery. IMC grade 2 cataract surgery is essential with correction 6.9, without correction 6.60. So this is a discussion you'll have to have with the patient. If the patient is comfortable, is able to carry out his routine work without any problems, has a correction of -2, 3, is able to accept the spectacles, is feeling comfortable with the spectacles, because some of the patients will not be comfortable with the spectacles because they hadn't worn spectacles any time in the past. So this is a discussion you'll have to have with the patient. If the patient is comfortable, I would have a follow-up after 3 to 4 months and see whether it progresses or not, and I'll observe. Major precautions to be taken to avoid endophthalmitis. Yes, this is an important topic. We have to ensure that the lid adnexa, there is no blepharitis, there is no source of infection in the lid. We'll have to stick to the pre-op protocols that is followed in your institution. Ensure that the patient is applying the pre-op medications according to the schedule that is given. Patient understands the need to apply the pre-op medications, and ensure that the intra-op goes well. And again, the job is not over once the surgery is done. It also comes down to the counselor to ensure that the patient sticks to the post-op protocol, post-op drug schedule. Once that is followed, then the chances of endophthalmitis is minimum. Vimal Dutt has asked, Mr. Vimal Dutt has asked how congenital cataract could be handled. Like I said, sir, congenital cataract is a separate topic that has to be handled separately. It is beyond the scope of this webinar. A phaco tip has balanced tip, straight tip. It will depend on the manufacturer, and each tip has its own advantages and disadvantages. Micro flare, mini flare. These are the types of phaco tips. If the mature cataract turns into phacolytic, what type of
So you may want to go through the rest of the questions and take maybe one more question, and
Okay.
we can type in the, you can type in the answers to the others.
Okay. If in a phacolytic patient, I would go for a SICS preferably, because the bag, the capsular bag will be very weak. It is far safer to do an SICS than a phaco. So posterior polar and posterior subcapsular, if the capsule is involved, the cataract and if the capsule is also opacified along with the subcapsular part, then it is posterior polar. Phaco can be done in both PPC and PSCC. We'll have to take certain precautions in posterior polar cataract. I'll answer the rest of the questions here. Can we go to the next?